Welcome to Civil Discourse, a podcast where participants are free to share their ideas, empathize with other perspectives, and who intend to advance to a better solution to fix a societal ill. We will focus on topics that are particularly complicated. In a time where information is from sources more opinionated than ever, our mission is to find solutions and goals to accelerate the nation's progress with cultural impunity. I'm your host, Todd Furniss. Hello, and today I have a great guest in the form of Dr. Steve Calvin. I want to welcome everybody to Civil Discourse hosted by Todd Furniss and remind everybody to like, share, and subscribe if you like our podcast here. I'm with Dr. Calvin, and Dr. Calvin, you've been a board-certified obstetrician and gynecologist for, almost 35 years now. Tell us a little about your journey and how that culminated in the Minnesota Birth Center.
Okay, well, thanks for having me, Todd. It's a pleasure. We only met about less than a week ago, so this is a good thing. So I went into medical school in 1976. So just to give a little context for that, ultrasound was not really routinely used. All kinds of interventions were happening that really had no scientific basis in maternity care. But anyway, I went in. I went to medical school down at Washington University in St. Louis, and out of my class of probably 120, I was actually one of the 10 students who really wanted to go into family medicine. I thought that would be a good thing until I realized that family medicine included crying children, and I really couldn't deal with that. So I did a summer mission trip during my college years in Mexico, and I also attended some births during that period of time. So I really found that I really liked maternity care. And so after medical school, I went to do a residency in obstetrics and gynecology at the University of Minnesota. I had a National Health Service Corps scholarship. I thought medical school was expensive at $3,500 a year, even down at WashU. So I signed up for a scholarship program for 3 years. And after my residency in 1984, I went down to Tucson, Arizona, where I'd actually grown up. My real roots are Minnesota, but I grew up middle school, high school, and whatnot in Tucson, and I learned to speak Spanish. So I went and worked at a National Health Service Corps, NHSC, FQHC, but a National Health Service Corps site for 3 years at the El Rio Neighborhood Health Center, which is actually a really well-run FQHC, not all are. And I did that 3-year service. And when I completed that, I'd been also a junior faculty member at the University of Arizona School of Medicine. And they said, "Hey, are you interested in doing a fellowship in maternal fetal medicine?" And I said, "Sure, that sounds good." And so I went and did that, completed that 2-year stint. So I'm an OBGYN, board certified in that, and also board certified in maternal fetal medicine, which is one of the subspecialties of OBGYN. At the end of that period of time, late 80s, because my wife and I have family roots in Minnesota, we moved back to Minnesota. So anyone that moves from Arizona back to Minnesota and stays here for 32 years is really committed to Minnesota.
Or just committed.
Yeah, committed is right. Yeah. And it was a good move, but for about 20 plus years, I spent my career at that point. I did some academic medicine things as a volunteer. I did some research, but I was mostly a high-risk OBGYN doctor, kind of an OB intensivist. So I tell people, I think I know every bad thing that can happen to mothers and babies, although every now and then I hear something and I go, gosh, I've never heard of that before. So I spent 20 plus years doing that. And in my mid 50s, I realized that night call every fourth or fifth night was not going to be conducive to living a long life. And so I was getting to the point of thinking that, Mrs. Olson was bleeding in the middle of the night just to make me mad. And that when you get to that point, it's time to change. So all along, I had been really thinking a lot about how we provide maternity care all the way from early residency days, just seeing a birth that just turns into like an emergency room scene, and it's not, it shouldn't be. Also, at the same time, in my mid-50s, my daughters and daughter-in-law were starting to have children, and I saw that maternity care was overly complicated, chaotic. It was not. It was providing, I would call it safety compared to the rest of the world, but a lot of iatrogenic harm, which we can talk about a little bit more. But at that,
Let me pause you right there, if I can, Doc,
sure.
because it seems to me that you're and what I find of a lot of physicians, this is the case, you're very mission oriented. You really care for the patients and you want to do the best for the patients. But it seems to me that your lens changed a little bit when your daughters and your daughters-in-law started having children. You looked at the healthcare industry from a user's perspective a little bit more. And obviously, because you can't have children yourself, your perspective as a physician was both as a physician, but also as a user. Would that be fair to say?
Yes, very much so.
So your lens changed, which caused you to have and actually be inspired to take that issue on.
Yeah, it did. I mean, I'm noticing too. I mean, there are a lot of physicians who now are going through medical school, and some of them never do residencies, and then they jump right into some kind of Silicon Valley startup regarding medicine, and so they've had a little 4-year kind of dip in the pool. I had 2+ decades of immersion, and so I knew everything that was going on. I also didn't understand much about billing and coding, and I just figured, I will take the best care of patients, trying to use the best evidence I can. But then it became clear that so much of how and why we do things is based on how the money flows. And I I was grateful to have a job that paid pretty well and provided a lot of exciting experiences and feeling like I was actually helping patients. But I just started to realize there is a deep fundamental problem here that needs fixing.
So all of a sudden, at the tender age of 50 something, you decided to become entrepreneurial.
Yeah, much to my wife's. I mean, she has been incredibly supportive. I call her, she's my angel investor. We have, and to actually make it happen. So what actually happened was in 2008, during the meltdown, during the initial financial meltdown, presidential election had occurred. My contract was up with my group of 16, and I'd been one of the 5 sort of founding members of the group. We were all employees of a hospital system, so I didn't really have ownership. But our contract was up, and I said, I need to do something different. We should start working with midwives. We should build a kind of a different system. And at that point, my colleagues, I might as well have opened a dirty diaper on the table, because they just, no, we're not doing that. So I actually just launched out, and I fortunately had support from a great neonatal physician group in helping me make that transition. But I basically describe it as cutting my income in half, cutting it in half again, and then deciding to basically utilize everything we had to build 2 freestanding, independent, but integrated birth centers, one in Minneapolis, one in St. Paul, which my wife refers to as the 401k houses now, because that's what they are. And then to just sort of launch into that with midwife colleagues, trying also not to burn my bridges with my colleagues in the hospital system, but to also really make certain that what we were doing was something totally different.
So tell me, what exactly were you trying to rectify by changing the process and the nature of care from early pregnancy or an identification of the pregnancy all the way through term?
Yeah, it's always been my thought that pregnancy is a great episode of care that can actually extend all the way to the first year of the baby's life. So I've always had that thought in mind, but I just saw all the things that were being done that were not, there was not a lot of evidence behind some of the things, as far as how many prenatal visits, how many ultrasounds, how much in the way of intervention. There is good data about what works and what doesn't. Sometimes that doesn't bode well for the bottom line of either physician groups or hospitals. And so I just saw that, I just said to myself, this is really messed up. And I naively thought the ideal thing would be to call up some of the managed care organizations, HMOs here in Minnesota. I mean, we're the hotbed of that, and say, hey, I got a great idea. And again, it was just sort of crickets, no, thank you. That doesn't fit our business model. So I just decided to start working with midwives, because in the US, only about 10% of births are attended by midwives. In the rest of the world, it's closer to 40 to 50%, depending on the country. There aren't enough OB doctors to fill all the needs. Anyway, so I went that direction. And then the model of care where midwives are actually the primary caregivers. In many settings in the United States, they're just seen as physician extenders, which is a huge mistake. They're colleagues and they do a really good job. And especially if it's an integrated system. So you're working between doing too much too soon or too little too late. And there's a happy medium. And I think we have found it.
So when as you know, I wrote this book called The 60% Solution. We talked about that. During the course of that, I researched a couple of guys. You're doing an excellent job of straddling right at the moment. On the one hand, the guy who's kind of the father of evidence-based medicine is Abraham Flexner. He's the guy that introduced the empirical method into med schools, did a bunch of good stuff, and did some stuff that we might not consider good today. And then Sir William Osler, who really was a strong advocate of the clinical responsibilities of going through the clinical education and saying, look, you can't just be in the laboratory, in the library. You've got to go actually talk to patients as part of your training. And what it seems to me you've done is you've taken that to the next step and said, hey, you do have to have both, and we can spike out in our individual capacities as colleagues one way or another. So the midwives may spike out a little bit more on the clinical side in terms of having a greater visceral sense of empathy, if that makes sense. Whereas you can not only have empathy, but you can also support that with the empirical side of medicine and spike out on that area. So it seems to me that this combination would be, especially with the respect you're giving to midwives as colleagues, very much do in all likelihood, is that you are actually delivering a better quality outcome because you're marrying these two different disciplines together in an integrated fashion. Is that fair to say?
It is. And another way of describing it is trying to marry high touch with high tech care, to just say, the whole comprehensive, the pregnancy episode, it's the most momentous period of people's lives, both mothers and babies and families. It's momentous. It's terrifying at times, but and everybody has their anxieties about it, but it's really important to just support mothers and families to embrace it as a normal experience, however, with the potential for significant complications. But that kind of risk assessment goes on continuously, and it doesn't always require giving birth in a high-tech operating room.
So you saw this problem, you experienced it firsthand, both as a practitioner and as a father, and now you've undertaken to solve the problem by creating a different delivery model with a different cost structure. So now comes the fun part. You can tell us how it's gone so far.
Yeah, well, it has been quite a journey. I ended up talking with a guy named Rishika Fernandapuli, founder of Iora Health. He told me a while ago, it's going to take you 10 years to get traction. And I'm now just past that 10-year mark, and he was right. It's, you can have the right ideas. You can have a situation where we now have had 3,000 births in our practice, some in the hospitals, some in the birth centers. Transfers to the hospital happen. They're reasonable and necessary. It's been a challenge to get things paid for. I took a look at, your state there in Texas for the Medicaid system. The amount of money paid to a birth center for all-in care, facility fee, and professional fee is $1,800. And I know I was complaining that it was $4,500 for us. Now we've talked that the state systems, the departments of human service and whatnot, they're paying managed care organizations somewhere in the range of $15,000 to $20,000. Now, of course, neonatal care is necessary too. But all that to say, we've had all these births. It has been a real slog to make it work. I feel real obligated, though, to provide health care for our midwives. Some birth centers are only able to stay open because the midwives are like independent contractors, and it is a huge challenge. Everybody recognizes it. And I know you're big, Todd, in transparency. And I just think transparency, both on the commercial side and the public program side, will be really, really important because money is there. We've got all kinds of issues with healthcare disparities related to race. I'm very involved in that for a whole variety of reasons, but also on a national advisory committee for HHS. All these things could be solved, and the evidence is there that a different model of care would work, but it's still running. I describe it as I feel like I'm trying to push an iceberg with a canoe at a time. And I'm paddling hard, but I also see that the iceberg is either starting to melt, crack apart, or it is actually moving.
So if you think about it, the problem, the economic barriers to your success include the entrenched economic value that's realized by the hospital systems for NICU units and by existing physicians, OBGYNs who want to use the hospitals as their the place where they deliver the baby. And so you've got this this integrated and self-reinforcing model of negative cost pressure, meaning costs are going to continue to go up. It's going to get more expensive, and there's a better model out there, which you're actually delivering and have shown to work. In Dallas, as I know you know, we have a hospital called Parkland, which is very famous in your little sector of the world. Delivers about 12,000 babies a year, which is a pretty big number. And I think it's bigger than 10 states combined. I don't know which states, but it's a big number. And what's happening by virtue of what you just described is a little bit more subtle, because Medicaid is paid for by state and federal taxpayers, right?
Yes.
Parkland has a tax on all Dallas County residents that's equal to about 1/3 of our property tax. So what's happening is, by underfunding through Medicaid, Parkland Hospital is funding through the tax payments on our houses. Does that make sense?
It does. Well, I guess, in education, that happens a lot. I mean,
Sure.
that's one of the others, but, I was not aware of that. That's interesting.
So if I were to look at it, and one of the things I can go back to the county commissioners and have a chat with them about is say, hey, did you know that, because right now Parkland their gross billed revenues is north of $3 billion, and they only collect about 10% of that, which means that the remainder is funded through state and local tax distributions. So what's happening ultimately is that the local residents here are contributing perhaps disproportionately to the cost of maternity care by virtue of our tax payments and the underfunding of Medicaid you just described.
Yeah, I took a look at some of the, per member per month rates throughout the various counties in Texas, and every state is incredibly complicated because Medicaid is a federal state program. Every state is different, and even every portion of every state is different.
Now, when you and I spoke last week, you told me something that was a stunning statistic, and it really surfaces for me right now as we're talking about this and the economics. Correct me if I'm not wrong. If I'm wrong, but I recall you having said that almost 50% of all babies born are born under Medicaid.
That's correct. All the way from some states, like maybe Utah, where it's 24%, to some states in the South where it's like 66%.
Wow.
So we're rapidly approaching half paid for by public programs. Now, in states like Minnesota, the federal poverty, the eligibility is like 275% of the federal poverty level. So some states like Minnesota and New York, Oregon probably are very, very generous. and I don't disagree that if you're going to spend money, that would be a good thing to spend it on. You just should be getting better value for the dollars spent, which kind of led me then to that birth bundle idea too.
Exactly. So let's talk about that. That's a nice segue into the birth bundle. Can you talk a little bit about that and what that means?
Right. So I did a little background research on, there was a few organizations commissioned a Truven study back in 2013 that looked at how much money was actually spent, not billed charges, but how much money was actually spent in a variety of states, commercial and public program, for maternity care. And it turns out it ranges, but in many places, commercial cost for a C-section and the pregnancy related to it, it's like $29,000. I mean, and it's definitely gone up since then. Medicaid payments are probably on the order of 11 to 12,000 for that sort of thing. So there's a lot of cross subsidization going on. And then when you dig deeper and say, where is the money actually going? Almost 2/3 of it go to facility fees for hospitals and for newborn care. And that's where the savings lie. That's where the fracking of the system can release actual value. When people say, "Oh, those physicians and midwives make too much money," that's only 20% of the overall spend. It really is facility fees. So I just started putting together a concept that we trademarked the name, the birth bundle, which is essentially a package of care from the prenatal care up through the intrapartum, so around the time of birth, and the facility fee for the birth center, also professional fees for the midwives. Our midwife team is able to attend births at our affiliated hospitals. So we do that. And we're also, because births are kind of fungible in general, they can move around in a community. We are also going to be working with our partner hospitals, and they will be our subcontractors for, if a mom needs to go to the hospital and needs care, she can do that. And then there's the whole aspect of neonatal care, which is probably almost 50% of the whole episode. That's where a lot of money goes down a dark hole at times. And a comprehensive team approach paid by as much of a single payment as you can get will get people to start working together. So it's not the anesthesiologist saying, "Hey, I need this much for my epidural," and the people who do what I do saying, "I need to be paid this much for the 5 ultrasounds we do." There definitely are times things really are necessary, but it's much better. And they're doing actually this in Kaiser, in the Kaiser system in California, where the physicians are paid a salary. They don't get extra for doing more work. Anyway, so that's why the birth bundle is really a single price for a real comprehensive episode of care. And we're trying to make it as comprehensive as possible. And it is getting a lot of excitement from payers. And ultimately, we all pay. Some of us pay because we make less money in the business that we work for, or the business that we own, or some are getting a bad deal because the taxes they're paying are really not paying for the highest value care.
So, can you give me a sense of roughly what a bundle would cost, or the price would be?
Sure. I mean, ballpark figures for some. It depends on how you define it. So, a bundle of a birth center care would be in the range of between $10,000 and $12,000 or $13,000, just in that range. I mean, I'm not giving a specific. However, if you take 100 mothers, and because they're getting care with midwives at a birth center, their C-section rate, and of course they need to be low risk, but most mothers are. If their C-section rate is even down by 5%, it dramatically improves the bottom line. And it's much better for mothers. If you can save them from a C-section with their first birth, you've done them a tremendous favor, because subsequently they either have to choose to have a C-section or a VBAC, and there are complications. And so we have really robust statistics. Of course, we have highly motivated mothers, but our primary first-time mom, head first term mother C-section rate is about 14 to 15%. The national average is like 24%. And that's, of course, some mothers would not choose birth centers, but we're finding probably a third of mothers would
Wow.
get, especially mothers who've already had a baby. Just as long as we have laboring tubs for moms to be in warm water, we have nitrous oxide self-administered, we have birthing balls, labor slings, all the encouraging stuff that is there.
And so describe a birth center then in terms of the number of rooms you'd have in the waiting room and the like.
Yeah. Yeah, it's more of a home-like environment. There are still mothers in the US who choose home birth. I'm not opposed to that. I'm not encouraging that, but there are mothers, and it's somewhere between 0.5% to 1% of all births. Certain parts of the country, a lot of home births, the Northwest for a variety of reasons. Anyway, so there are mothers who just want to be away from a hospital. There are other mothers who say, I kind of want that ambiance. I want a home-like atmosphere that's not a hospital, but it has all of the facilities and backup to do neonatal resuscitation if necessary. And so the two birth centers we have, our one in Minneapolis is a renovated Victorian house that has 2 birthing rooms. And the one in St. Paul is more of a more modern building that has 3 birthing rooms. And that's where mothers give birth. And each room has a tub and a bed and a bathroom and a shower. And then there's clinic space as well, education space, which of course hasn't been used as much during COVID. But a birth center it's more of a friendly environment for encouraging normal birth, but with all the backup and safety net that is required.
And how many births would you see in a day or a week in one of your birthing centers?
Sure, we're doing about 450 births per year in our practice. We could probably do 600 with 5 birthing rooms. So, in any given month, each birthing room should be around 10 births per month. I mean, it varies because there's turnover, and most of these moms are not laboring for days in a birthing room. They have their baby, and then they actually go home within 8 to 12 hours.
And 10 births per month per room?
Yeah, I'm trying to just make sure I've got that correct. Yes, that's right. Yep, 10 births per month per room is kind of what we've calculated as working for the model.
Right. So to look at, and I'm sure you're not familiar with the Parkland cost structure, but if you were to draw an analogy to your safety net hospital up in Minneapolis, what would their cost be for the same bundle of services, do you reckon?
Well,
notice I'm saying not their price, their cost internally.
Sure. Well, they could change that cost. I mean, they could make it different. In fact, I never would have built 2 birth centers if they would have been willing to do it internally. I mean, they were building a multi-million, I think $70 million new maternity tower, and they had a couple of floors they were just going to shell in. And I said, we should put a midwife unit there. It'll attract mothers, and midwives are quite, they're quite active in Minnesota with many of the big systems. They're still in many ways seen as physician extenders. But anyway, I offered that. And then when I went with the birth center route, one of the administrators of the hospital system asked me what it would take for me to give the idea up. I said, well, the end of the world, maybe, but even then I'd probably still keep doing it. And I asked, why are you asking that? And she said, because our doctors aren't going to like it and it's just going to mess up the model, And I said, well, the model needs to be kind of messed up at a certain point so we can redesign it.
So what I'm looking at is I'm saying we could actually realize a savings that would mean a reduced loss if we adopted your model, especially if there were partnerships with the hospital systems that said, hey, we're going to take the NICU cases that are acute and send them there. That would make all the sense in the world. And in return, it'd be helpful to get some referrals perhaps out of you and distribute the burden. And for a large metropolitan area, we have in our SMSA here in Dallas, we have, right around 6 million people. But we have, a lot of hospitals as well. But there are concentrations, obviously, of population where the density is such that it can warrant probably more than a couple of centers in an area. But you're raising some really critical issues, and I think that you're uniquely positioned to have the kind of insight that very, very few people would have the ability to provide. So, I'm really, just for one, I'm genuinely grateful that you've taken the time and really invested not only your time but also your treasure to go make a model work that really can help change the industry and especially affect so many moms and newborns.
Yeah, and one final thing I would say too is that there is a study that was done by the Centers for Medicare and Medicaid Services. They have an innovation center, and as part of the Affordable Care Act, Obamacare, there was a study done called the Strong Start Study, done between 2013 and 2017 on 46,000 mothers, and they focused on outcomes. They looked at a variety of three things, but one of them was birth center care with midwife-led care. And they found that the outcomes were dramatically better with midwife-led care in birth centers, and that it significantly narrowed the racial disparity gap in preterm birth, all kinds of empowerment, especially of mothers of color. So it's frustrating because that actually was, the results came out almost 2.5 years ago. They were essentially shared with all the Medicaid agencies around the country. And it's still, there's just, hesitation. I do have a sense that the current administration, the new CMS administrator, I don't know if she has been confirmed yet, but her name is Chiquita Brooks-LaSure. She's very knowledgeable about this. And so there will be pressure on a federal level, and then some innovative state agencies are going to go, this maternal mortality and newborn outcome racial disparity thing is real. And there's a whole variety of reasons. It's not very simplistic, but it's real. And there are absolutely proven ways to fix it. This is one of them.
Well, that's fantastic news. And it seems to me that there's a bunch of good that comes out of this. And the argument is likely to be something along the lines of, yeah, but they're not adequately trained, or they don't have adequate access, which is it sounds to me like economic interest speaking rather than medical doctors speaking. So I understand that. I am really intrigued by this, and I'd like to chart your progress over time and have you back if you don't mind. But I'm really so thankful that you reached out and that we had a chance to talk today. I think what you're doing is very innovative, even though you've been around for 10 years. To me, it's and the practice of midwifery has been around for a long time. I think that the approach you're bringing to it is really a very nice marriage of science and practice. So thank you for that. And thank you for your time today. I appreciate it.
Great. Thanks for having me, Todd.
Thanks for watching this week's episode of Civil Discourse. To learn more about today's topic or our guest, visit www.the60percentsolution.com or www.tfip.group.